Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Striker.
Welcome to Central Line. I'm Dr. Adam Striker, editor and actually one of two hosts with you today because I am joined by my colleague and Central Line guest host, Dr. Brooke Trainer. Today we're going to talk about several issues that are prescient and certainly pertinent and discuss some of the implications for anesthesiologists. So, Dr. Trainer, welcome to the show. Welcome back
Hi, Adam.
to the show.
Good to do this with you again. Maybe we got a little interest in our last hot topics, and they're trusting us to do this again.
Yeah, exactly. Well, that's right. We at least didn't burn the house down.
That's right.
The last one, right? Well, we want to touch on probably several issues for this session. And Brooke, you were at the ASA Legislative Conference this month in Washington. And so you were front and center on some of the hot button issues that are affecting anesthesiologists. And we're going to probably choose a couple of these to discuss right off the bat. But the one I wanted to start with was CMS implementing reduction in anesthesia conversion factors and just implementing reimbursement cuts. Why don't you go ahead and give us a little bit of background on it and the implication for all of us?
Yeah, Ledge Conference is always eye-opening. You get to see what the national issues are and what our priorities are. And of course, reimbursement cuts are always at the forefront of some of those discussions. And this one is a big one. So this has been a recurring problem. We used to do this SGR fix every year. We come back again, and then they fix the standard growth rate, the SGR. But we still don't, in anesthesia, have a tie to any inflation factor. And so what happened again this year is CMS implemented this 2.83% reduction in the anesthesia conversion factor. It doesn't sound like a lot, but when you're already like scraping the bottom to be able to make ends meet, it has huge implications. So I wanted to convey to our audience what that really equates to and why this is really important for CMS to get right and fix. And so if you don't mind, I'd like to go through the numbers a little bit.
No, go ahead.
Too messy. Okay. So right now, last year in 2024, CMS reimbursement was time-based. One unit is about 15 minutes of anesthesia time. And so this unit, it was about $19.58 in 2024. And so with that cut, it brought it down to $19.02 per unit. Okay, so this, conversion factor that they apply, first of all, they apply it to Medicare Part B. Part B is the part of Medicare that pays physicians. So again, what are those margins? When we're already razor thin, right? Every little cent matters. And so time units, they're calculated, like I said, 1 unit per 15 minutes. So for, let's just say, a routine case, an hour case with a base unit of 6, we might be talking about 10 units. So that's $190 for the whole case. But what is the breakdown? Where does that money go? So you break down what anesthesia unit actually cost to deliver, you got to consider the anesthesiologist compensation. So doing that math, that's about $12 to $15 per unit. And if you have a CRNA also working, that's about $7 to $8 per unit. Malpractice that we all pay, $1 to $2 per unit. And then all your administrative staff, a couple bucks, equipment, medications, monitors, disposable, that's easily $1 to $3 per unit. So then don't forget about your EMRs, your IT, your reporting requirements, your compliance, all the things, okay? When you add it all up, the true cost of delivering 1 unit of anesthesia care usually lands between $22 and $30 per unit. And we're being reimbursed $19 from Medicare. So that's not just a cut, that's an operating loss. And any sound business-minded person would say it's time to close practice. It's time to close shop. So if you're a really heavy government anesthesia group and you service a lot of government patients, you might be considering closing up or maybe cutting back on your staffing or merging with larger health systems so you can stay solvent. So there's a lot of implications here, and this really has the potential to impact access to care.
Well, and it's not just private practices. There are going to be effects on employed anesthesiologists too, or in health systems at some point. Right now, the supply and demand for anesthesia staffing is such that it is in favor of the practicing anesthesiologists, but that can't last, right?
Yeah, I think you'd start thinking about like other downstream consequences. You not only impact your access, you're now going to put more production pressure on the anesthesiologist. You're already short staffed. You're going to try to scale back even further, try to skimp with fewer resources. So fewer providers covering more shifts. I think teaching hospitals would take a hit as well because you don't have time to train residents. You're taking fewer residents on, or, maybe you don't bring them in because of more cost pressures, especially if you're not supplemented, and you're paying for that staff yourself. I think ultimately, though, the thing that really is important to consider here is the patient safety risk. You have overworked clinicians and underfunded systems. That's definitely going to increase your chance of errors. And it's really the patients that are going to suffer in all of this. Those are the unintended consequences. ASA, the Legis Conference, was really great because it got us in front of the legislators to talk about this. And it was optimistic, I would say. I was optimistic anyway with the folks that I was able to talk with. And the doc fix is simply applying an annual inflation adjuster into the budget reconciliation, like into that package that could permanently fix this problem so that we are not here every year over and over again with the threat of having to drop this reimbursement that's already less than our cost and basically grovel to get enough money just to make ends meet. So it was optimistic, but still, I'm not sure that there was complete support for it.
Did you hear why, in spite of bipartisan support, why was it not included in the most recent funding package?
That's a really good question because it's interesting that a lot of the other sectors of Medicare had that inflation adjustment included. It's just anesthesia didn't have that in there. So it's a perpetual problem, this broken physician payment system. And I don't know. I think it's going to be the death knell for the ability of physicians to sustain clinical practices if it's not fixed. So I think legislators were hearing that. I think they were understanding that. But I imagine it's a huge administrative burden or task to get something into the budget reconciliation in general. So maybe that's a limitation.
And it seems like every year, at least recently, it's been like this last minute fix and something gets done in some fashion, but it's always year after year there is this concern. And I'm not diminishing the concern because every year it becomes dicier and dicier whether something gets done. And at some point that has a significant effect on practices and, as you pointed out, personnel and their ability to deliver safe practice, even if something does get done at the last minute without being able to plan on inflation adjustments and appropriate reimbursement for expenses. That has a slow boil type of effect, does it not?
Exactly. It comes up every year and, maybe we should expect it, but it's really hard and it's a lot of stress that you put on the system to make those adjustments. And again, it's at the cost of burnout of your clinicians because you're reducing your staff. Letting go of people is not something to take lightly, right? And then burning your clinicians out, not something that you really want to do if you don't have to. So it'd be nice if they could find a permanent fix to this. And that's what the doc fix was.
And you brought up a good point about the burnout and the increased production pressure, which is going to contribute to that. And also, more importantly, potentially compromise safe care when clinicians are burdened too much. And that's why I think that it's important, even for employed anesthesiologists who may not directly deal with this on a day-to-day basis, but it is important that they realize the ramifications because, as you alluded to, with the staffing crunch and the fact that perhaps hospitals have to subsidize compensation because of that, there is still a limiting factor to not only subsidization, but the ability to procure staff. And at some point, the private practices certainly see this, but even with the
Absolutely.
hospitals having to shore up their operating expenses, that is going to significantly affect a group's ability to procure staff and retain staff, and it will have that downstream effect.
Yeah. And I think this is why this is relevant to every anesthesiologist, regardless of whether you're in a private practice, in a teaching hospital, or, where you are. It will result in reduction of staff by, administrators saying, listen, we can't afford you. And so I think we have a duty here to act not only on behalf of our patients who deserve great access to care, but also on behalf of our own colleagues and ourselves to say, hey, listen, if we don't want to have to strain the system and risk burnout and risk all the other consequences of that, we should probably be reaching out to legislators and letting them know of these consequences, educating them, taking this opportunity to familiarize ourselves with the problem so we can be prepared, but also maybe help be part of the solution in getting this fixed.
No, absolutely. It's a great segue into the next topic that I wanted to talk about, which I believe was also discussed at the Ledge conference, also related to insurance, which is the issue with the Medicare Advantage program upcharging the government for complexities in patients that really do not have those complexities, costing taxpayers significant amounts of money. If you don't mind, talk a little bit about that issue, give our listeners a little bit of background if they're not familiar with it, and then where it currently stands.
So if you recall our last episode that we did on this, we talked a lot about the Med Advantage plans. So this I had a chuckle at because I was like, I knew it. This is a system that's just fraught with fraud and problems. I said, I could predict this, You give this big bad bully the purse strings, they're going to find a way to exploit this and take advantage of it. And so that's exactly what this is. And by the way, what I'm going to say here is the solution or the budget offset to the doc fix, right? So if we can hold big health insurance companies accountable and correct some of these upcoding problems, if we can offset that, it could pay for the other fixes that are really needed in the system. So what they've done is they've sent nurses into the patients' homes who are Medicare recipients or Med Advantage recipients, and they'll do what they just call an assessment, or they'll call it a social determinants of health assessment, or a community practice program. I mean, they label it these really fancy terms, but it's essentially a ploy to get a nurse in the home to find out what else could be wrong with this patient. And they get a nursing assessment that is documented. Meanwhile, there's no physician involved. There's no legitimate physical assessment or, history and physical done by a medical doctor or even an advanced nurse practitioner to determine that this is a legitimate diagnosis. But they've figured out the diagnoses which don't require a physician diagnosis, which don't require a diagnostic test. I can't even tell you exactly what diagnosis codes they're using because as a physician, I never even heard of them. They mentioned them in LegCon, but I can't recall because it's something very obscure and super rare. It's like a diagnosis of exclusion code that they're using. Like when you can't figure something out, you use this because you don't have anything else to go by.
Mm-hmm.
So for example, they come in, they see like a patient has, pitting edema, but they don't have another diagnosis that explains that. So they'll call it this. But the important thing is they're upcoding. So they're finding additional obscure diagnoses that don't require physician's assessment or treatment or any test. And then when you submit these 2 to 3 comorbidities, you're able to move to a new tier of reimbursement. So where like an episodic payment might be, $1,500 for like let's just talk in anesthesia terms, ASA 1, if you figure out enough codes and you can code them an ASA 3, again, I'm talking anesthesia terms, that's not how they do it, but if they can find 2-3 more comorbidities and code for it, then you're going to get reimbursed $3,000 an episode, right? And then when you compound that with, they're now holding again the purse strings and dictating to the provider what they're going to reimburse. And they're contracting with the providers, the physician groups, at much lower rates than what they're getting from Medicare. So even when they upcode these patients, there's no translation of that percentage of receipt that's being given or passed on through to the providers. They're keeping all of that. And so this is aggressive tactics to make money off of taxpayer dollars while still continuing to restrict procedures, deny prior authorizations, and set up really harmful payment practices. The Wall Street Journal actually published a couple articles.
They did a series of them.
Yes.
And it goes back a couple years and exposed a lot of the details that you have highlighted. The legal ramifications are murky. As you stated, at the very least, it's unethical. They were incentivizing patients for some of those home nursing visits with gift cards as financial compensation. They got access to chart reviews, certain doctors' offices, and if they saw a diagnosis, they would apply a coexisting medical condition that didn't even apply. They would continue applying those even after the patient was treated, an example of cataracts. So an incredible high number of patients diagnosed with diabetic cataracts, even if they didn't have diabetes, and even if the cataracts were just mentioned in the chart, even the ones that were, which is a low incidence in general, were treated with the lens replacement, they still kept those diagnoses on so they would get reimbursed. And the government certainly didn't have the wherewithal to audit all. They do audits, I don't mean that, but there's so many charts. It's an impossible task to hold each incident to account. But, interestingly, there was also the HIV thing. I don't know if they talked about that. I know there was the increase in HIV diagnoses.
Oh my God.
Through
No,
these
we didn't
means
talk
too.
about that, but that's interesting.
Yeah, this was in the journal in their initial investigation, but there was a high incidence of untreated HIV diagnoses, which goes against dogma compared to traditional Medicare. And that was another point of highlighting these crazy practices that now the insurance company, of course, takes issue with the investigation, but it's pretty obvious that there is some pretty shady practices going on here.
Exactly.
And in fact, recently in March, there was the case against United Healthcare by the government was thrown out because they couldn't prove their case, I guess. However, this just came across that United Health Group is now under criminal investigation again for possible Medicare fraud. And this is related to the Medicare Advantage program like we've just been discussing. And I guess the Justice Department just launched another criminal probe.
Yeah, the Department of Justice investigations and whistleblower lawsuits, it's exposing billions of dollars. They calculated like $50 billion from 2019 to 2021 that due to diagnosed patients with conditions that triggered extra payments, even though no doctor saw them or ever treated the disease. Some of the rumors out there are that home healthcare agencies were being tasked to do this, but it wasn't made clear that was what was happening. But they were incentivizing these agencies to go out and do these extra visits, paying them per visit rates, probably minuscule compared to what they were actually getting back. I doubt it was any percentage. But, Dr. Oz, now the CMS administrator, he commented in his committee hearing, the Senate Finance Committee hearing in March, I believe, that he was noticing that the Med Advantage plans were costing way more than what regular Medicare.
That is true. Yes. Yeah. That's what the journal had uncovered as well. That's significantly more. And just to back up, so our listeners know, if I'm not mistaken, the idea behind the Medicare Advantage program originally was to utilize the private insurance industry to help more efficiently care for patients, because traditional Medicare, you would be reimbursed for any test ordered or procedure done, et cetera. And the government worried about that being an incentivization to order more tests, do more procedures, and you would just get paid per thing done. So the Medicare Advantage program created allowing the government to just pay a lump sum for coverage of a patient, regardless of their conditions. And the thought was the private insurance companies would be incentivized to keep those patients healthier because, anything that they're getting a lump sum reimbursement, they're not being paid for tests necessarily. But then to offset the idea that some insurance companies may get stuck with sicker patients who end up costing more, they allowed them to bill or get reimbursed for patients with more complex diseases, as we're talking about. But as we know now, that has been abused, and to the point that it, as you just said, it has significantly increased the cost to taxpayers through this program as opposed to traditional Medicare. I mean, to the tune of billions of dollars.
Yeah, what you were describing was the fee-for-service programs.
Mm-hmm.
But maybe now there's some momentum with all this going on to go back and reevaluate this whole idea of paying episodic payments for a patient, because I actually think that's an attractive solution, but pay it to the providers, pay it to the physicians, incentivize the actual people who actually can impact that patient's outcomes. How is it that we can expect a payer to make a patient healthier? How does a payer make a patient healthier? They don't make the patient healthier. The physicians, the providers, the caregivers, they're the ones that make the patient healthier. So why not incentivize them, right?
Mm-hmm.
We're incentivizing the wrong people here.
Oh, yeah, absolutely. I mean, again, as we discussed in the last episode that we talked about the insurance industry, I just think it continues to highlight how overly complicated we have made the delivery of healthcare in this country. I mean, we've gone so far afield from the basic idea of a caregiver and their patient, and it just continues to create more and more of a mess the more that we delve into these issues and try to deal with it this way.
Right. And I think this is a good segue to talk about the third thing they talked about at Ledge Conference was the safe VA care. And the reason I think it's a good segue is because if you can imagine privatizing VA, right? That's always been something that's talked about. Get the VA closer to the community. Let the veterans go into the community care.
Mm-hmm.
But look what's happening. I think this is an example of what could happen if we did that in the VA. If we allow essentially commercial business to come in there, commercial payers or private groups to care for veterans, then there's going to be an incentive to upcharge, to bill higher, and that's going to be, with the VA pay, right? So that's a different government entity, government payer. So let's learn from this, let's learn from the fact that there's always going to be fraud, waste, and abuse in every system. But
Yep.
You got to look at who's more capable of harm here, right?
Yep.
This is a much more harmful situation and much more exponentially problematic situation because of how powerful and systematically capable these payers are to do this. One provider that's causing fraud, waste, and abuse is never going to be able to rack up this kind of fraud, waste, and abuse.
Right.
So.
Exactly. It's such a good point. This marriage that's necessary between the private and public sector for these big ticket items, there has to be that relationship. But the idea, I think, that just privatizing something in and of itself is going to be the solution is just simply not the case in many instances. And this is an example of that. The idea of doing that with the VA, as we just discussed in the Medicare program, how that solution in and of itself is just too simplistic for the complexities involved. The reason I say it that way is the idea that you need both. You need a private sector that's helpful. You need the government to tackle these problems. You need both to work together, and they both can make mistakes, as I think the
right.
The Advantage program pointed out.
Yeah, and I think they kind of keep each other in checks and balances. Giving too much power, too much authority to one group is a bad idea for these reasons.
Yeah.
Yeah.
I couldn't agree more. Well, I'm sure more to come on that. We'll see how that shakes out with the investigations and whatnot. Anything else on the safe VA care discussed at the Ledge Conference?
Oh gosh, yes. So Unfortunately, so I do have some background into the VA. I'm a VA anesthesiologist, and I was past president of the Association for VA Anesthesiologists. I've been one of the forefront leaders in this scope of practice expansion fights, where we strongly, oppose it, mostly because of the fact that veterans deserve the highest standard of care. And we know that the majority of states across the US are physician-led anesthesia care. And that's proven to have, the best, patient safety outcomes. And so we are strongly still opposed to any expansion of scope of practice for CRNAs without any problem that we're solving. And so what I think is really interesting, the VA is continuing to come up with creative problems for their one solution. And it seems to, again, when we debunk one of the problems, which is there's no shortage of anesthesiologists, there's no access to care problem, at least in surgical care. Well, they find something, they find something else. Well, we want to standardize practice. We want everyone to be able to go to any state and work in any VA. Well, guess what? You can already do that because any license in any state qualifies for you to practice in the VA. Okay, well, we want it to be irregardless of state law. We want them to be able to do whatever it is we say they should do. We want to create this national standard that trumps every single state's laws, medical boards, associations, what the AMA says, what ASA says. We don't care. It's what the VA says, right? This is the mentality. This is what is presented, and this is what's on the table. So at the legislative conference, heard, though, that we have, again, a lot of support from legislators who are on the appropriate committees, one being the Appropriations Committee that is in charge of funding, one being on the VA committee. So that is vocal in opposing any change in practice that does not improve or strengthen the quality of care for veterans. And so Greg Murphy and David Scott, both members of Congress, have a letter that they're circulating and getting signatures on to go to the secretary. And I think
bipartisan, right?
Bipartisan, yeah. And so I think they've been pretty successful in at least staving this off. Remember, this goes all the way back to COVID, where they got this idea that they were going to push this national standards of practice. The idea for CNA scope of practice goes all the way back to beyond my time in the VA. But I guess it's never going away. I think just some more education. And so that was, the goal is to get out there to the legislators and educate them further on some of the, issues, that this is a solution in search of a problem, that the veterans, they don't want this standard weekend.
Well, right. Even with the access to care issue, if we can debate the merits of particular access to care versus the risks of what care is being accessed, but even if access to care to anesthesiologists were limited, it still ignores the fact that these patients are incredibly complex, and not having a physician involved in the care at some point, whether it's supervision, whether it's personally delivering, whether it's prescribing an anesthetic, whether it's, reviewing the patient's medical history and weighing in on potential anesthetic and thereby surgical decision-making, it ignores how important and how imperative it is. And without that these patients are certainly at risk, lesser quality of care. And I still feel like even with that, the access to care argument, even if that were true, it still ignores that fact.
That's right. Yeah. And I'm going to just point out that it contradicts that any policy that implements this standardized practice way of doing things, even that terminology, because to some, we're standardizing care. That sounds great, so that everybody receives the same care. But really what that does is it limits the care that is able to be provided. It's always great to implement protocols and stuff like that, best practices. But this top-down approach, creating these national standards of practice in silos behind closed doors, only with top executives, right? We don't even know what they're going to say or what they want to say. They just keep saying this all the time. And the final conclusion is CRNA should practice independently. But what does that look like? And why are the frontline physicians not helping? Why are we not being involved in this? And so that contradicts VA's own high reliability organization principles, which emphasizes safety through team-based tiered accountability, right? We work, and this is something that I think is really important here, because they also try to make similarities between the VA and DoD. Well, you and I both know those are way different populations, but also the DoD, has recognized that in dynamic, challenging, complex environments where patients are very complex, it's physician-only teams. I was a critical care air transport physician, so I flew patients in and out of combat zones with injuries, providing care in air, sometimes surgery in the air, and getting them out of harm's way. But those were the sickest patients. Like, we had alert teams that were the lung rescue teams, putting patients on ECMO, getting them out there. There's no CRNAs on our team. It's only a physician. It's me, another physician, maybe a surgeon, ER doc, and ICU nurse, and a respiratory therapist. But I'm leading the team. I'm calling the shots. There's no other advanced practice provider on these teams. So even in the sickest situations or complex environments, it's us only, right?
Yeah.
Well,
that particular, what your experience, it shows the critical necessity of, if at all possible, to have physicians involved in the medical care, especially in situations that are increasingly complex.
Correct. Yeah.
Well, Brooke, it's been a pleasure as always to talk with you. And these are important issues. And I think the issues don't always have to be specifically about anesthesiology for anesthesiologists to care and make a difference, and highlighted by the big ticket items that you started off discussing. As physicians, anesthesiologists are going to be affected by all these items. There's a wide breadth of issues that you can get involved in and try to help with at some level. But also, I think it's important for everybody to at least know about them, because these issues affect all physicians.
Exactly, in many ways. So
thanks again for joining me. And again, it's great to talk with you, and I look forward to being able to do this next time.
Thank you. Yep. Till next time.
And to our listeners, hope you enjoyed this episode of Central Line. Please tune in again next time, and take care.
Hi, this is Dr. Scott Watkins with the ASA Patient Safety Editorial Board. The World Health Organization, WHO, defines patient safety as the absence of preventable harm to a patient and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. In order to better understand how safety in healthcare is managed, clinicians should be familiar with three philosophical approaches to safety engineering, referred to as Safety 1, Safety 2, and Safety 3. The Safety 1 perspective assumes that accidents, errors, happen because systems or their components malfunction or fail. In contrast to Safety 1, the Safety 2 perspective shifts from ensuring that as few things as possible go wrong to ensuring that as many things as possible go right. Safety 3 is grounded in systems theory, which posits that accidents occur when safety controls within the system fail to adequately handle threats or disturbances. In order for safety in healthcare to continue to evolve, then all clinicians need to understand safety engineering and take an active role in designing healthcare systems.
For more patient safety content, visit asahq.org/patient safety. Gather fresh insights from notable experts, uncover the latest advances, and boost your knowledge of current practices and standards at the Anesthesiology Annual Meeting, October 10th through 14th in San Antonio, Texas. Learn more at asahq.org/annual meeting. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.